Hello and welcome to Doc Talk Live with NorthBay Healthcare. With us today is pulmonologist Karan Julka, and he's going to talk about progress being made in lung cancer diagnosis.
All right.
Take it away, Dr. Julka.
Well, thank you so much. I'm Dr. Julka, I work with NorthBay. I'm one of the pulmonologists here. And it's very nice to have you guys all visiting with me today. So I want to talk about something that's near and dear to my heart, which is lung cancer, and specifically lung cancer diagnosis. Kind of just walk you through this sort of mystery of how do we get to figure out if somebody has lung cancer, and all the tools and things that we have available to really get you to that point. First and foremost, let's talk about lung cancer itself. It's a devastating disease. It is the second most common cancer for both males and females. The most common cancer for males is prostate, and most common cancer for females is breast. However, lung cancer causes the most amount of deaths in both cases, both for males and females. Lung cancer, from a diagnosis standpoint, about 15 to 17,000 people just here in California got diagnosed with lung cancer last year. When you just look at our county, which is Solano County, about 250 people got diagnosed with lung cancer just in the last year, and that's pretty relatively about the same every year. So it's a condition that occurs quite commonly, and it occurs quite often, and it's something that we feel very strongly about. Let's walk through this with a patient of mine. So usually, majority of our patients who find a spot in their lung find it not because they are having a lot of symptoms, but rather because they had a CAT scan, often of their chest or the belly, for some other reason, not related to the spot itself. They'll have this CAT scan. Their primary care doctor or emergency room doctor might tell them, you have a spot in your lung, and that's how they come to see us. Often, my job is to kind of look at the spot, understand how risky it is, and then decide on what next should be done. From my standpoint, I sort of look at the spot in different ways. So I'll look at it on the CAT scan as well as Xrays, and I'll try to see where it is, if it's in the upper part of the lung or lower lung, how big it is, and then make decisions on what comes next. Majority of patients who have lung cancer are ex-smokers or have never smoked. About 65% of patients generally get the cancer but are not actively smoking. So often we look at lung cancer as a smoker's disease, but majority of people are not smoking when they actually get it. And that's very challenging. So just looking at people who smoke, I think is not good enough. I think we should look at everybody who has risk for lung cancer and risk for being somebody who may have issues with this. So some of the risks for lung cancer, of course, smoking. If you were a smoker in your life and smoked at least 20 pack years, what that means is you've smoked at least a pack a day for about 20 years on and off, and that puts you at a higher risk for a spot in your lung being lung cancer. You should be over the age of 55, and that also puts you at a higher risk of lung cancer, especially if you're a smoker. If you quit smoking in the last 15 years and you're between the ages of 55 to 80, that also puts you at a higher risk for having lung cancer. So those are the kind of things I'll look at when I look at this spot. If a spot is over a centimeter, that's a higher risk for lung cancer. If it's in the upper part of the lung, it's higher risk for lung cancer. If you have multiple spots and they're all small, it's a little lower risk for lung cancer. Once we've sort of made the decision that what we're looking at is a higher risk or a lower risk, then that kind of gets us into how do we diagnose or what do we do next? So the next step from once we have identified a spot is to really say, how do we tackle this spot? And there's lots of different ways we can do that at NorthBay. We can do that by just imaging again, which is the most common way of following these spots. So if I have somebody who comes in and has a 6 millimeter spot, I'll often recommend not biopsying or doing anything else, but repeating the scan in generally about 3 months if they're at higher risk for lung cancer. And the idea behind that is you want to see if a spot will actually change. Will it grow some? The biggest concern I get from my patients is that won't it spread all over? They've watched TV, they've watched the news, they've watched maybe a movie where just cancer goes from very tiny to very big very quickly. And that's not how cancers work. They grow, but they grow very slowly, especially when they're very tiny. They do not spread very quickly. unless they get much larger. And so when we find spots that are very tiny, the better thing to do is to follow and not immediately start getting into cutting on somebody or putting needles in their body, and allow that to slowly evolve. So most often I'm actually just repeating a scan. In some cases, if it's a little bit larger, we may consider doing what's called a PET scan. And the PET scan essentially is a way to look at spots in the lung or elsewhere in the body to see if something has a potential of growth. PET scan gives a very special dye. It's basically a sugar dye. And sugar goes wherever there's lots of cells trying to grow. And so if you have a spot in the lung and we get a PET scan and lots of sugar goes in that area, then we're going to be worried that that's an area that could grow in the future much faster, and that may be something that we're going to be worried about. If you have the right size of spot, let's say about 1 centimeter or more, you're at high risk for lung cancer. Depending on where the spot is, we'll take the next step. And the next step may be either a bronchoscopic guided biopsy. That's where we'll put you to sleep. We'll go inside your lungs itself and go way out in the lungs and try to biopsy this spot directly from inside the lung. Or we may do a transthoracic needle aspiration biopsy. That's where we usually put you in a CAT scanner, have you lay back, and put a needle directly in from the outside of the lungs into the inside and biopsy it that way. Both are quite good. Both come with their own sets of risks and issues, but both will allow us to figure out what's going on with this spot. The other thing we have here at NorthBay, which I end up doing for a number of my patients where I have concerns for lung cancer, is called endobronchial ultrasound guided biopsy. This is a special type of biopsy that looks at lymph nodes inside your lungs. We do have to go inside your lungs, so you're put under, and you're completely asleep under anesthesia, and we get to look at the lymph nodes. And the lymph nodes are little spots in your lungs that essentially are sponges. They gather up cancer. So if you have cancer and some of your lymph nodes are a little bit bigger, they will largely gather up this cancer and keep it there. And it's a lot easier to biopsy them sometimes than the actual spot that may be far out in the lung, and to get the information we need. So I think we have a lot of ways of figuring out if somebody has cancer, but most commonly people who come to me with spots don't have cancer. In fact, only about 2 to 6% of patients that have spots in their lungs actually have cancer. So majority of my patients who come to me with a spot in their lungs, I don't need to biopsy them. In fact, I may not need to do too much with them at all, except to follow the spot on CAT scan and just make sure that it doesn't grow, it doesn't go to hurt them in the future. And I think that's something quite helpful to understand and know, because most people who have a spot in their lung, who get told by somebody they have a spot in their lung, they get extremely scared. And their first thought is if they're loved ones, their thoughts are for themselves, and they're worried about if they're going to die from cancer. But majority of the time, in fact, more than 90% of the time, even if they were a smoker, even if they're smoking now, the spot in their lung will not be cancer. And I think that's very important to understand. All right. Lastly, I just want to talk a little bit about being defensive about lung cancer. So we know that we can find spots and we can biopsy them and we can get you answers, and we have wonderful people who can help you decide on the right treatment and so forth. But how do we become defensive about not getting the spot, or if there's a spot, finding it early? Because the earlier we find lung cancer, the better we can treat it, the less risky it is for you in the future. The way to do that is really, if you are a smoker, if you've been a smoker in the past and you're the age between 55 to 80, you should be part of what's called a lung cancer screening program. Lung cancer screening works very much like a mammogram screening. Mammograms are done for breast cancer in women of appropriate age. Lung cancer screening is done in patients who've been smokers or ex-smokers of appropriate age. And we do a very special CAT scan called an LDCT, a low-dose CT scan. We do that yearly, and we're looking for little tiny spots, things that we would never biopsy, but we just want to keep an eye on them. And if we find one and it starts showing some growth potential or is growing, that's the one we would concentrate on. That's the one we may biopsy. And so it allows us to be defensive, find things very early. And big studies that have been done here in the United States have shown that this type of strategy of finding things early can save lives and save a lot of heartache that occurs when we find lung cancers late. All right. So with that, I'll kind of stop and happy to take questions.
And just a reminder to those who are watching, if you have a question, you can type it in just like you would a comment on any post. We'll be able to see that and pass it along to Dr. Julka. I have a question based on what you were just talking about, that 90% of your patients, it's not lung cancer. So what is it? What causes spots on our lungs that aren't lung cancer?
Yeah, I think that's a great question. So the question is, if the spot is not cancer, what is it? Well, I often tell my patients, what is a freckle? Sometimes we don't know. It is just a spot. So majority of spots, in fact, we don't quite know, but we have an understanding of what they can be. We know from lots of studies that a lot of spots, especially in this area, are related to a type of fungus that grows in the soil. If you are from Ohio, like I am, the fungus is called histoplasmosis. That's very common to be from Ohio and have little spots in the lung. If you're from California, where I now live, there's different fungus called coccidioidosis that's often in our soil here that'll cause these little tiny spots. It does not mean you're infected, it's just exposure, meaning that you might have had some of it go into your lung at some juncture and your body decided to fix it by putting a wall around it, and that's what that little spot looks like. In other cases, there can be chemical exposures that can cause little spots in the lung. I often get asked if dust exposure will cause spots. Not often, unless you are somebody who is used to cutting things like granite. If you're a granite cutter, that type of dust can cause lots and lots of spots. If you are somebody who grows chickens, the chicken feces itself, when it gets aerosolized or goes up into your nose and inside your body, that can cause lots and lots of little spots to appear. So spots can be lots of different things, but the good news is majority of those things are benign and they don't lead to anybody passing on. And in fact, even if you have lung cancer, we can make it better, and we have amazing ways of doing that. But the trick to lung cancer is to find it early so we can fix it.
You talked about CAT scans and PET scans being a common way that something is spotted. What about X-rays? Is an X-ray even going to be able to see a cancer?
No. And that's again, great question. Do X-rays help us find cancer early? Can we use X-rays instead of CAT scans or PET scans? And the answer has been looked at. X-rays on a yearly basis, even when done on patients that are high risk, meaning they're smoking and they're at a high risk of having lung cancer develop, do not find cancer early. Part of the reason is just the way the X-ray is taken. It's very hard to see small spots. So the earliest we would be able to see a small spot in an X-ray would be at least when it was 1 centimeter. But really, in all honesty, probably more like 1.5 to 2 centimeters, which for us would be too large of a spot. We want to find things much faster than that. On the other hand, a CAT scan can find a spot as small as 0.1 or 0.2 millimeters. What that means is it's 1/10 of the size that an X-ray can find, we can find on CAT scan. So I think from our standpoint, the CAT scan, especially a low-dose CAT scan in the appropriate patient, is the best way to find spots early.
Okay. When you say finding it early, what's the optimum? How early do you want to find lung cancer?
We would like to find lung cancer before it becomes a problem. What that means is that we find a spot, we understand that it might have growth potential. We find it at a size, generally we're talking about less than 2 centimeters, where we can biopsy it easily, and it has not gone anywhere else in the lungs, including the lymph nodes. It is just where we found it. That gives us the best chance at cutting it out of the body so it can cause no further trouble. That's how early we would like to find it. However, even if it's spread to a local lymph node or two, that does not mean that we can't cut it out of the body and fix it. It's just a little later stage. So if we can find cancers at stage 1 or 2, that helps us and our patients the most in terms of getting them through it quickly and efficiently.
And when a cancer is diagnosed, how does that work in terms of working with an oncologist and the pulmonologist together?
Absolutely. We have in NorthBay a great set of oncologists right here. We share a lot of information together. I have all their cell phones. So when I find somebody who has a cancer, once I've diagnosed them and once I feel like they're ready for treatment options, we often will have a multidisciplinary approach, meaning that we get into the same room, the cancer doctors, myself, radiation oncologists, the surgeons, as well as radiologists and a pathologist, all come together to discuss that one case. That rather than that patient going and seeing 10 different doctors, 10 different doctors can look at their information all at the same time. And we can together as a committee say this is the best treatment for them. For many of my patients, when we find these cancers early, they never need to see a cancer physician. They need to go from me directly to the surgeon, have that part of the lung cut out so that the cancer cannot spread. So they do not need to see a cancer physician at that juncture. If we find that it's a later stage cancer, they definitely need to see a cancer physician, and that's done quite easily because we have this multidisciplinary approach. So we try to be very, very quick with not only diagnosis, but also the treatment side.
So during diagnosis, you were talking about two different ways to biopsy, one going inside of the lung and one piercing the lung with a needle from the outside. How do you determine which one is the right one? It seems like piercing the lung would be a little scarier than going in.
I think both have. I think that's a good question. So how do I make the decision as a physician on how best to help my patient? So for depending on where the spot is, how close to the ribs it is, how far into the lung it is, that's what's going to help me make the decision on which way I can go. If possible, I like to biopsy as many of these spots from inside the lung as possible, specifically because the side effect profile in terms of what kind of things can happen to you when you have a particular procedure is a lot lower when I biopsy from the inside of the body versus when we have to biopsy from the outside with a needle. So I think from my standpoint, if it is a spot that I can get at and I can biopsy from directly inside the lungs, that is my preferred way of doing things. However, for many spots, that's not the right way to do it. If they are too close to the ribs, etc., that's not going to work to go inside the body. And in that juncture, we will use one of our interventional radiologists who are excellent at this, and they will put the needle in from the outside. Even though it's very scary when you hear about the needle coming from the outside, they make it fairly painless. They usually have the patients given some medication so they feel comfortable. They're not under general anesthesia, so you will kind of know what's going on and you'll feel certainly some things, but I think they do a great job.
And when you go is that sort of like using a scope, the way they do in a colonoscopy, only down the throat and into the lung? Yeah,
so our scopes, much like a colonoscopy or what we call an EGD, are quite a bit different. So the scopes we'll use to go inside the body are extremely thin. I tell people that it's no thicker than the end of this pen. Essentially, that's the type of scope we're using. On the other hand, the scopes that are used for doing colonoscopies, they're about this thick, so they're quite a bit bigger than what I use. So I use a much thinner scope, and majority of our cases, we will have our patients completely asleep under general anesthesia. They don't know what's going on. There's no pain inside the lungs. There's no pain receptors inside the lungs. So what we biopsy, needle, things like that, there's no pain for our patients while they're going through the procedure. But majority of them are fully asleep for the procedure. They wake up, they don't even know they've had it, and majority of them go home within an hour after the procedure is complete.
And what are the age groups you said that should start doing regular checks? Yeah,
great question. So I think the people who are the age of 55 to 80, who have smoked at least 20 pack years, that means at least a pack a day for 20 years or so, or half a pack a day for 40 years, those patients are at the highest risk for potentially developing cancer and should talk to their doctor about being part of a lung cancer screening program.
What about people who just, occasionally when they were out and about, they would smoke or?
Yeah, so social smokers maybe smoke just here and there. they don't carry the same risk that somebody who regularly smoked does. So unfortunately, they would not be generally considered to be part of a lung cancer screening program. But anybody who's smoking, I always tell them, please quit, because even though the risks are fairly small, there's always a risk. And so we try to get everybody off smoking as possible. For people who may have quit smoking in the past, who might say, well, I've quit smoking, so my risk is down to nothing, I would tell you that if you have quit within the last 15 years and you're between the age of 55 to 80 and you did smoke at least 20 pack years in the past, you should still consider doing the lung cancer screening, and your doctor can talk to you more about that, but you would qualify for lung cancer screening because those people still carry a higher risk.
I'm also curious about what's the survival rate with lung cancer if you catch it early enough, as you talked about.
Sure. So if we catch somebody with, let's say, a centimeter lesion or spot in their lung, we know that that's the only place it's there. There's not gone to any lymph nodes. We cut that cancer out of their body. The survival rate is nearly 100%. Wow. And so that's why it's so important to find these spots early before they kind of start spreading around, and that we consider that stage 1. But by each stage, the survival drops some. But as time has gone on, our oncologists have better and better medications. So even when we have now later stages of lung cancer, those people can stay around and be with their loved ones for a long time.
Is lung cancer, the longer you don't know about it and it's growing in there, is it more likely to spread than, say, other cancers like breast cancer or ovarian?
I think it depends on the type of lung cancer it is. So there are certain types of lung cancers that almost don't spread. They can take years to spread. And those are cancers that I know it's cancer, but I've just watched for 5 years or more by CAT scan. On the other hand, there are some types of cancer, like small cell lung cancer, that can spread fairly quickly. It can spread over just a matter of months instead of years. And so I think by default, some lung cancers definitely spread much faster than cancers in other places, kind of for breast or prostate. But prostate is a very good example of a cancer that in majority of men who are older who have prostate cancer, the cancer does not spread. It does not spread very quickly for sure. And so when you compare against something like that, lung cancer is much faster in its spread.
Okay. What are some common symptoms someone might have with lung cancer? Okay.
So great question. So symptoms that patients will come in with often are not always related to lung cancer, but we'll catch sometimes lung cancer in the midst of the symptoms. So the most common symptom that brings patients to somebody who might do an X-ray or a CAT scan is coughing. That tends to be the number one reason why somebody might get a particular type of image. However, it's not necessarily related to the spot you have. You may just have coughing. It's just that we did an X-ray or a CAT scan and saw the spot. The next most common symptom that will often trigger X-ray or CAT scan is chest pain. And in about 7% of patients, something like 5 to 7% of our patients, they'll actually cough up some blood. Now, when I talk about coughing up blood, most people almost always think it's cancer. That's what they've been trained, or that's what they've seen on TV. But in fact, it's actually one of the last things that may happen is that you cough up blood. And unfortunately, most of the time people cough up blood and they have lung cancer, it's usually at a later stage. We do not see coughing up of blood with early stage cancer. We see that with late stage. So by that time, unfortunately, things have spread a little bit, and that's why the bleeding has occurred. But majority of the time, people who you even cough up blood, it's for other reasons like pneumonia, not for cancer. So I don't tell people to wait till they have symptoms of coughing up blood to get checked out. I think you should just get checked out anyways. Hopefully, without any symptoms, should have the lung cancer screening. But however, if you're clearly symptomatic, you're having lots of chest pain, lots of coughing up of blood, then you don't need to be part of the lung cancer screening. You need to clearly come see us so we can do a CAT scan and do other things to figure out what's going on.
Do you have any specific suggestions for how people can try quit smoking?
Absolutely. I think there's a lot of resources that are offered by California, by throughout the country for quitting smoking. I think I take quitting smoking kind of like bringing a horse to the water. If the horse is ready to drink water, I think they will drink water. So I think the first thing about quitting is to actually say you want to quit. And I don't force any of my patients to quit, but rather just have that conversation. Quitting is a difficult process. It is often a process that fails, and I think you have to be ready for that. So I think it's a minority of patients who quit and stay quit. I think majority of patients quit start throughout their lifetime. In fact, for majority of people who stay quit over a long period of time, they've at least tried to quit 3 to 4 times before they were successful. So I think the first thing to do is to tell yourself, I want to quit and I want to stay quit, and I'm not going to lose faith if that doesn't happen, but I'm going to keep trying. The second part of it is to sort of figure out what happens when you've tried to quit before, or what's going to happen when you quit. Are you somebody who mentally has a difficult time handling it, get emotional, get hard? Are you difficult to live with when you're quitting, essentially? Or are you somebody who doesn't have that issue? Are you somebody who's tried before with different things like nicotine patches and so forth, and strategy doesn't work? Are you somebody who needs a counselor, somebody to talk to through it? Do you need a group to visit with of people who are trying to quit smoking? So I think when you see your physician, when you see your pulmonologist, that's the kind of discussion we should have. Targeted therapy to help you be the way you want to be. Not one strategy for everybody, but rather different strategies, and often multiple strategies. I often have my patients who want to quit smoking on medications to quit smoking in terms of pills, but also nicotine patches or nicotine gum or nicotine inhalers to cut out their cravings when they're happening. But that strategy, again, is not for everybody.
What's the first step to be part of the lung cancer screening program at NorthBay Healthcare?
The first part is to have that discussion with your primary care physician. Your primary care physician can then look at this information, make sure that you meet the criteria, and then get you over to one of our nurse navigators who's actually going to walk you through the program and kind of keep an eye on you during the program. And that's how the process should be started.
Is there anything else people should know about getting screened and fighting lung cancer?
I think that people should know that if they do have lung cancer, there's lots of therapy, there's lots of hope, and that they should never give up, and we will help them through it.
Okay. All right, our time is up for this chat, but we want to remind viewers that you can join us next time with Dr. Nazia Hassan, who's going to be talking about GERD on April 22nd at 1:00 p.m. right here on the NorthBay Facebook page. Thank you, Dr. Julka.
Thank you very much for everything.